There you go. Good morning, everybody. For some reason, the recording button was being stubborn today, but we've powered through. Happy Thursday. Thank you to all who are able to make it live. It makes it that much more special. And I would really encourage all of you who are watching on YouTube to consider joining live and maybe even presenting a case. Today, we have a first-time case presenter, Samir. Samir, I would love to say hi, get to know you a little bit better. Do you mind telling us a little bit about yourself?
Yeah, so I'm Samir. I'm a fourth year med student at Baylor College of Medicine in Houston. I'm originally from Houston, and I'm excited to be presenting for the first time and joining you guys.
Oh, we're thrilled to have you, Samir. Tell us a little bit about your life outside of medicine. What do you do outside the vortex that we're in right now?
Yeah, gosh. I'm a big Rockets fan, Houston
Oh,
Rockets. So
nice. Yeah,
the
yeah,
NBA draft was last night.
yeah.
So I'm excited to see how this year pans out. I also like to bake, and I like to
Mm.
run.
Nice. Oh, awesome. Wow. You're like, so my favorite thing in the world outside of medicine is to run, and my wife's favorite thing outside of medicine is to bake. And so I feel like you're combining two very handy skills where you get to go exert yourself and then indulge thereafter. I'm curious, what is your baking repertoire? If you were to tell us what symbolizes you in that space, what would it be?
So I try to keep it balanced. I like zucchini bread, banana
Mm.
bread, incorporating some
Mm.
fiber into my baked goods.
Nice. Yeah. Oh wow. Awesome. I love that. That sounds we had some delicious zucchini bread on our travels yesterday. Big fan. What about in medicine? What do you see yourself going into in the future?
Yeah, so I'm applying this fall into internal medicine.
Nice. Gotcha.
And so that's the main goal right now.
Awesome. Awesome. Well, that sounds so exciting. And thank you for putting this case together and being here. We're absolutely thrilled to have you. And it's not just a Samir first, it's also Vijay's first time discussing with us. And I think that if you've been part of VMR for any more than about 24 to 48 hours, you'll know Vijay. He's actually probably one of the most long-standing VMR attendees since the very days, the origin of VMR. And we've seen him navigate many parts of his training journey. He's currently a training in pulmonary critical care in India. And he's blessed us with many a case before joining the academy and continues to bless us with his wisdom. Now, having been in the academy for a few months, Vijay, we're very excited to have you. How does this feel compared to presenting a case? Does it feel a little bit different or the same?
I think, hello everyone. This is Vijay. I am a pulmonary critical care trainee from India. Uh, happy to, excited to be discussing a case. Although presenting seems easier, uh, there is,
Yeah.
there is the rush of discussing the case as well as a sense of nervousness of what is to come.
Yeah,
So,
100%.
excited to be here.
We're thrilled to have you. I totally understand that, and it never really fully goes away. Thank you to Zachariah, who's scribing for the first time, and Elena, who's doing teaching points. Samir, whenever you're ready, we can try to take on your first aliquot.
All right, let's do this. So we have a 55-year-old gentleman who's presenting with dyspnea and left-sided chest and back pain. Would you like
Go
more
ahead,
history?
Vijay. No, whatever you have planned is we're ready for it. I know you put a lot of work to try to decide when you is this where you had planned to stop?
Yeah, so let me give
Yeah.
you guys some more background. So
Okay, sounds good.
16 days ago, he underwent left percutaneous nephrolithotomy and ureteral stent placement for left inferior pole staghorn calculus, causing obstructive uropathy. His immediate post-op course was complicated by urinary retention that prompted Foley catheter placement that remained upon discharge, which was the next day after the procedure. 1 week later, he presented to the emergency department with dysuria and left flank pain. The Foley catheter was removed after successful voiding trial, and a course of cefpodoxime, tamsulosin, and oral analgesics were prescribed, though he did not know any significant improvement in his symptoms. Over the last couple of days, in addition to the left flank pain, he has begun having dyspnea on exertion and left-sided chest pain that's worse with deep breaths. The pain and dyspnea have continued to worsen, the dyspnea now occurring even at rest, and that's what's prompted his presentation today. He denies any cough, fever, chill, sick contacts, nausea, vomiting, diarrhea, rash, arthralgia, or really any other symptoms. This has never happened before.
Thank you so much. I mean, this is such a really interesting case. And I think, Vijay, just to make a quick point about clinical reasoning in general before passing the microphone to you, I think it's always tricky to know what to do with accompanying information. And by here, I mean that the fact that he had this recent procedure and has all this going on, because it's not mandatory that the patient's core clinical syndrome be explained by something that happened to occur recently. It could be completely true and unrelated, or causal. So I'm really curious, before you and I study the accompanying clues, how much progress we can make on the core aspects of this case, which must be explained. And so I think in this case, what the patient is coming in with, the fact that he's short of breath, has left-sided chest pain, back pain, that must be explained. So I'm curious what progress we can make of that alone first, before we then use the accompanying clues to our advantage, rather than tunnel vision that these accompanying clues may provide. So I'm really curious what you think of just the chief concern of this case.
Yeah, very rich, Alakot. So, given that this patient was completely fine until the procedure, and all of these symptoms just noticed only after the procedure. So, is it a complication of the procedure, or is it two different processes that are happening? Is what I'm thinking. So here we have dyspnea and chest pain. So it makes us think of a cardiopulmonary cause. Um, so what could it be further? So given that there is a left-sided chest pain and it is increasing on deep breath, so is there a component of pleurisy that is there? I'm thinking of. So if it is pleuritic, why only left side and why not? If not, usually is bilateral. So if it is left-sided, so is there a left-sided process that is happening? Like, is there an infarct, or is there a local cause from below, an abdominal process? Or is there something from the outside? Is there any skin lesions or anything of that sort? And a physical exam would be helpful here in just navigating through what other process it could be. Given that there is also an accompanying back pain. So this is a little concerning. So is it only the reflection of the pleura that alone we are thinking of? Or is there something vascular is another thing that is very concerning, because we don't want to miss out some things like a dissection. Also, is it just a part of the post-procedure? Is there a pneumoperitoneum that was created, and then is it was there a part of the surgery itself? Is another thing that I'm thinking of. Given that this patient underwent the procedure for a staghorn calculus and obstruction, however, there is no relief in the symptom. So that is another thing that is making me think, given the adequate procedure that is done, the patient has no improvement in the symptom. So is there another process that is happening intra-abdominal that is causing all of these? Is another thing that I'm thinking of.
Yeah, I think that your thinking is absolutely superb, and I'm right there with you. And I would say that um, I think that there's a high degree of confidence that Samir is presenting to us a plural story, and I think the thinking behind that can be taken back to the unique situation of chest pain featuring shortness of breath, and the combination of chest pain and shortness of breath. Fundamentally, what chest pain means is that there is something going on in the core thorax. And the value of shortness of breath is it tells you that something deep is happening within the thorax, i.e., something in the chest wall alone would be implausible to cause accompanying shortness of breath if there's nothing else going on. So you immediately know that you are dealing with something deeper in the chest, either the heart, the lungs, or the mediastinum. The good thing about the lungs themselves, from the perspective of this, if there is just primary pulmonary pathology, that does not cause pain because the lungs are not innervated. And so you can immediately knock out the lungs and say, is there a cardiac cause, a pleural cause, or a mediastinal cause? And that's when you realize that the unilaterality of this and the very fixed unilaterality, it's not just unilateral for one day, it's been unilateral consistently, i.e., rigidly unilateral. So you have in front of you the heart, the mediastinum, and the pleura. You say, which one of those things is rigidly unilateral, let alone worse with deep breaths? And I think the question is really the question is, what is the pleural process going on? And fundamentally, there are three different kinds of pleural processes. There is air, acute pleural processes. There's air that escapes into the pleural space, a pneumothorax. There can be ischemia of the pleura, or there can be inflammation of the pleura. And so I think, as you said, we know now that our gaze is going to be to try to see if the exam or imaging corroborates this leap that we can make fairly confidently. And then the question becomes, why would this person have a pleural process? And we'll, of course, refine that question to why would this person have pleural air, pleural fluid, pleural ischemia? And I think it is going to be very important to understand the context in which this is happening to make progress. We may come to the conclusion that he has this pleural process completely unrelated to what happened to him previously, but more likely, as you said, given how, given the proximity of the symptoms and the fact that he had no problems before, it gives it a high, strong probability. But I really just want to emphasize the progress that you made, which is unilateral chest pain and shortness of breath, unilateral, is almost always a pleural disease process for the reasons we walked through. And so what pleural disease? Air, inflammation, or ischemia. And I think with the exam, we'll be able to make some progress. All right, Samir, tell us more, please.
Yeah, so past medical history, type 2 diabetes, lost A1C 5.5. He also has a history of nephrolithiasis. His only medication is insulin. Family history is only significant for type 2 diabetes in the mother. Social history is a former smoker, 5-pack years, quit 30 years ago. No current alcohol or drug use. He works in construction. No allergies. Moving on to vitals, temperature 98.4, blood pressure 122/74, pulse 89, respiratory rate 21, satting 96%. Exam, he's general and acute distress, cardiac, regular rate and rhythm, no murmurs, gallops, or rubs, no JVD. Respiratory, he appears tachypnic. He has decreased breath sounds in the left lung. Abdominal, he has left lower quadrant tenderness to palpation, also with left CVA tenderness to palpation. Extremities, he has no lower extremity edema, he has no rash. The surgical site appears clean, dry, and intact without any warmth or erythema.
It gets more and more and more intriguing. Wow. All righty, Vijay, what did you latch on to in terms of this next round of data that Samir provided to us?
So I'm just looking at the past medical history and the other history if it can make any help. So diabetes fairly being controlled, although presence of diabetes does not rule out possibility of a cardiovascular, macrovascular complication. So I would just be thinking that in the back of my mind if something else that can be ongoing. And given the physical exam that is helpful here, there is no significant tachycardia that I'm seeing, and there is no hypoxemia. The patient looks fairly mild tachypnea that is there. So the physical examination strengthens our initial possible diagnosis of a pleural process predominantly. And what is the pleural process? Whether it is air or ischemia or inflammation. So here, the presence of reduced breath sounds mean there is some filling process inside. So it could be air or it could be a, a fluid that could be there, and there is a tenderness to palpation. So is it just the part of a pleural process itself? Just to this one, what is a CVA? Can you just help me with it?
Yeah, it's
Left CVA tenderness.
costovertebral angle.
Okay, okay.
I think it means costovertebral. Yeah, so flank. Yeah.
Flank. Okay. So is it the patient underwent a recent procedure as well? So is that just a part of that itself? Or is there a primary renal plus a pulmonary process that is involved? So there is no skin or other lesions that is there. So I just don't want to miss the ruling out a pulmonary embolism. But this history goes fairly a little against the diagnosis, the physical exam. Although there could be a PE with an infarct that could cause something similar, where there could be a reduced breath sounds as well. So I'm thinking, uh, is this mostly infarct, or whether there is a effusion as well? So, and but the only thing that is making me think a little against is just the vitals being just having mild tachypnea that is there without significant hypoxemia.
I completely agree with you. I think I'm right there with you, my friend. I think it's an interesting case to make progress on. I think I agree with you that the presence of diabetes should really make us uh, cautious to before we lock in on the pleural based disease process. I think that's really, really key. It's really interesting to try to make progress on the exam on whether this is air or fluid. And I think you could make progress with some physical exam maneuvers, but in the modern era, I think what you continue to teach us is the value of point of care ultrasound in this circumstance. And I think that would be incredibly powerful. Uh, I think this case does emphasize that most patients with unilateral pleural disease processes do not have enough lung impairment to develop hypoxemia. And so the fact that this person is compensating for that is very, very in line with that. The question that I'm trying to figure out from this exam is to say, does this person have two separate problems? Does he have an active problem in his pleural space and an active problem in his left flank? Or is this is this a problem that is referred, i.e., there's only a problem in one of those two areas and the symptoms are being felt in other areas as well? Um, I think that the point that you make about the possibility of a pulmonary infarction is really important here. And just because there's a space occupying process, either air or fluid, does not eliminate that possibility, especially because the patient could have PE with infarct and have an exudative or hemorrhagic effusion from the PE. So I'm really curious, what do you imagine might be helpful if you were taking care of this patient in your actual practice? What do you think you might be able to do that can help you make a lot of progress right now?
Yeah. So I think the first thing would be a point of care ultrasound. I think half of the differentials that we consider, whether it is primary lung or pleura versus an abdominal, I think all of that we get a better understanding of the same, and then go for a CT of the
I'm so sorry, Vijay. I'm not sure if my internet is glitchy or yours, but I heard go for it, and then I lost you, but it might be my
Okay,
very bad
sorry.
internet.
So I would go for a point of care ultrasound that would
Yeah,
help
yeah,
an abdominal as well as a thoracic process, and then go for a CT thorax and an abdomen to get a further clarity of the same.
yeah, 100%. I'm right there with you. I think the question becomes immediately, is this air? And the point of care ultrasound will be able to answer that, and that will put you on a different pathway. If this is fluid, then I think I don't envision a way that we don't sample it unless we get a CT with contrast that shows us that the patient has a pulmonary embolism and an effusion in that category where we might say this is a pulmonary infarct. I think this goes to show you the value of getting contrast. And I'm curious, Vijay, just to learn from you, if you get a point of care ultrasound and it rules out air, um, and you're thinking about a pleural process, how could you decide when to give contrast to when not to? So I guess as a pulmonary critical care physician, how does how do you decide between a CT chest with or without contrast for a pleural disease?
Yeah. So I think of what is the pretest probability I'm thinking of. So here it is an acute process. So we have to make sure that we don't miss out something life-threatening. So always contrast helps when we are thinking of uh, especially not to misdiagnose like an embolism. Otherwise, if I'm thinking a very clear, only isolated pleural process, I think an HRCT would be sufficient. If not for any masses, I would look for an infiltration. Only then I think I would go for a contrast.
Yeah, I just wanted to thank you so much for making that point. I think in this case, the probability of error is a little bit lower in large part because of how long this has been going on for. Pneumothoraces tend to declare themselves more quickly, either by becoming more serious more quickly or by going away and resolving by themselves. And so I think the fact that this has persisted makes me lean much more towards fluid. And so I think in most cases where you really need to know what's going on in the pleura, you often need contrast. And I'll emphasize that that's the exception. In most patients who have a pulmonary pleural disease process, you'll see us getting CT chests without contrast. That's in stark contrast to abdominal CT scans. So why is the default to get a non-contrast CT chest in most cases? The default is because air is a fantastic contrast medium. It is contrast for free. So that's why you can see your area of consolidation very good because it's surrounded by air and the air allows you to clearly see that pattern. So in most instances in the thorax, air gives you great contrast and is not needed. So what do you need contrast for? Three things: to opacify vessels to look for PE and aortic dissection, to see inflammation in the pleura, because the pleura, once it has fluid, should not have air in it. So if you want to try to see evidence of inflammatory pleural disease with overt loculations, nodular enhancement of the pleura, you need contrast. And then finally, to see the mediastinal structures better, lymph nodes, masses, contrast is helpful because it allows you to distinguish mediastinal structures from the great vessels with more clarity. So said simply, most patients with lung problems get a non-contrast CT scan because air is a great contrast medium. There are three exceptions to that rule: thoracic vessels, like the chest, like the pulmonary artery and the aorta, inflammatory pleural diseases, and mediastinal structures. And in this case, I think that the context of an infection that he has in his urinary system, plus the possibility of a pulmonary embolism, has me predicting that his path will contain a CT chest with contrast. Ultimately, that CT chest with contrast might be diagnostic if it shows a PE, but really will just reinforce the idea that he has a pleural effusion. So EJ, let's just play this out because part of our jobs, especially in hectic situations, is to try to anticipate the future. So what chances would you give the possibility of a thoracentesis in this case? How likely do you think the patient will need a thoracentesis for diagnostic clarity? Would you say that's low or medium or high? What do you think?
I think definitely I would keep somewhere it would be high if the vessel is something clear, because we don't want to miss out on anything else that is there because it is unilateral. Whenever we have a unilateral process, I think it always warrants a diagnostic evaluation for the same.
I completely agree with you. And now the hard question. Do you think that this pleural effusion, what do you think? Would it be exudative or transudative?
I think it would be mostly a transudative because we have a lot of signature for an inflammation that is there. So I think it would be more of an exudative process.
Yeah.
Because there is pain, there is inflammation involved.
Yeah. Excellent. Excellent. So this is absolutely fantastic. It's been such a pleasure to dance with you. And I'm slowing us down here because my goal is to show you how much progress you can make. On the history, we were very concerned this person has a pleural process. On exam, it's been reinforced. And we, based on the time course and the lack of severe symptoms, are prioritizing fluid. Most of the fluid that we're entertaining is going to be exudative in nature, but there's one very important consideration here in this context in which the effusion might be transudative. And if the case turns out to be something different than that, at the end, I will come back and make that point so you all think of it now. But I agree with you, Vijay. Very likely, unless this patient has an infarct on CT chest, he will need a thoracentesis, and more likely than not, it'll be exudative. But there's one diagnosis, which may not be the case here, but we should think about it. And I'll share with that at the end if it's not the actual diagnosis. But I will pass the mic to you, Samir, to tell us how this case evolved for you all.
Yeah, so I'll give some basic imaging as well as labs. So white blood cell count 8.4, normal differential, hemoglobin 13.2, platelets 393, sodium 140, potassium 4.5, chloride 107, CO2 23, BUN 26, creatinine 1.5, baseline is around 1, glucose 147, calcium 9.4, AST 18, ALT 27, ALK-Phos 62, albumin 4, GFR 55. On UA, 2 plus leukocytes, 2 plus blood, RBCs greater than 182, white blood cells 175. EKG and troponin are negative, HIV negative, and we did get CT abdomen and pelvis with contrast. I'll give the read for the abdomen and pelvis portion right now. It said left hydroureteronephrosis with hyperenhancing urothelial thickening of the renal pelvis and ureter suggestive of UTI or reactive post-procedural inflammation.
What do you think, Vijay?
Yeah. So how is the lab helping us to make progress? So there is so the counts are normal. So I'm thinking there is no overt inflammation that is there. At least systemic inflammation that is not there. Is it only a local inflammation in the pulmonary pleural system? Given the creatinine, okay, there is a mild increase in the creatinine. So here so the creatinine is increased from the baseline, and the glucose is normal. So, and we have a UA showing RBCs as well as WBC. So is it post-procedural, or is there an glomerular involvement that is there? So most likely, I'm making a assumption that it should be post-procedural. But I would just keep it in the back of my mind, not to miss out on if there's something glomerular that could be happening, involving both the cardiac as well as the renal system. Apart from that, the sodium, everything is normal. So the CT abdomen, so the HUN is present. So is it? So this is a knowledge gap that I have. How long does it take if post-procedural, if there is an improvement, whether the HUN completely resolves or it takes some time? So what is the time it takes? I'm not really sure of that. The thickening, as it mentioned, it would be just a chronic process that is there, or is it post-procedural? So I'm not sure how I can make a progress of that thickening that is there. So apart from that, how does it help us in navigating our differential further? So I think the abdominal process, fairly, there is nothing else apart from on the renal HUM that is there. So probably the flank pain, I'm assuming, is because of the HUM that is there. But why there is a persistent HUM, or it would take some time longer for it to resolve. This is one thing, and the thickening. So is the HUM part of just because of the upstream HUM thickening of the bladder that is causing the HUM? But however, there is only unilateral and not bilateral. So if there's a chronic bladder thickening, that should be causing the HN. So I'm assuming it has to be bilateral. So since it is unilateral, so I'm thinking mostly it is just because of the calculus and upstream involvement.
Yeah, absolutely superb, Vijay. I too, like you, I'm struck by the lack of overt inflammation here. That, we were wondering whether this process is inflammatory. It might be inflammatory and localized to the pleura, but it is not at least systemically inflammatory, which reduces the probability that we'll find something inflammatory in the pleura. And I think that's the progress we made with regards to the systemic evaluation. And I also have that knowledge gap. I'm not sure how long it takes for the hydronephrosis to resolve after the urologist tried to fix it, but I would imagine that 16 days is long. And so looking back now, I was trying to remember whether they just did a nephrolithotomy or whether they put a stent in, whether the stent failed or not, because I think that would be an additional consideration, but it looks like there was no stent placed. So the question is, does the patient have ongoing obstruction? And so in the face of that knowledge gap about the time course, I would use analogical reason to say 2 weeks is a long time. And so I would venture to guess that the patient has ongoing urinary tract obstruction. And I agree with you most of the time that you have unilateral ureteral obstruction. The most common cause of that is in the ureter itself as a result of stones, strictures, or masses. And here you don't see a stricture, you don't see an external mass, so it's likely an unrecognized stone, that underappreciated stone, or maybe a stricture as a result of the procedure. It is important to entertain the possibility of the bladder being a cause of unilateral hydronephrosis when there is a strategic lesion at the ureteral pelvic junction. So if you have a unilateral bladder tumor right there at the exit of the UPJ, you can get unilateral hydronephrosis, and I've seen that once. Of course, the bladder process will ultimately expand to cause both sides, but no different than you can have a foreign body aspiration affect just one side of the lungs, causing a right main stem occlusion. You can have an airway problem causing unilateral lung issues. You can have a bladder problem causing unilateral hydronephrosis. But here, I think the context of that is very. So what conclusions have we made? We are very suspicious of a pleural process. But now we have the context of active obstruction in the pelvis to frame that pleural process. And I think that framing is very, very important. So no longer are we worried that the pleural process is referring to the CVA. We now have proven disease in the CVA. And once we clarify what that pleural process is, we can start to draw the connections between the two. All right, Samir, tell us more. What do you have next?
Yeah. So blood culture, urine culture without growth. I do have 2 slides of images I'd like to share, if that's all right.
Please. Yeah, go for it.
Hopefully you guys can see my screen. So this is a chest x-ray. Left is postoperative day 8 when the patient's symptoms were confined to the flank, and then on the right is postoperative day 16 when the patient was having both flank pains and dyspnea and chest pain.
We have an expert in the house, Vijay, of pulmonary critical care. So, Vijay, what do you think of these X-rays? Teach us, please.
So, yeah. So I think given that it is postoperative day 8, patient is completely normal, and postoperative day 16, there is a complete opacification, almost opacification of the left hemithorax. So, and there is a convex appearing margins, meniscus sign that is there. So I'm thinking mostly it is a significant pleural effusion, although there is no significant mediastinal shift that is there. So probably it's a moderate effusion that is present. So underlying, if there is any parenchymal process, it is difficult to tell at this point. But so what happened between day to day 16 that caused this? So that is what is more concerning, because um, why should him have, and even the flank pain, I think, was almost simultaneous. So I'm thinking if this flank pain caused it, or is and still difficult to make links between the same. So other thing is, I'm not sure if so post procedural we can have urinothorax as a complication. So is it a urinothorax is what I'm thinking of this. And uh, is there underlying, so what is the flank pain for? So maybe we will see whether we can have a thickening or a biopsy or something, tissue diagnosis for why is there a persistent HUN that is there.
I think that's superb. Now you're saying, okay, I have a pleural effusion in the context of obstruction. Urinothorax describes this condition where, because of the high pressures that the urinary tract system is under, in addition to causing hydronephrosis or fluid between the renal capsule, the fluid can be under such high pressure that it leaks into the thorax. The leaking into the thorax is also augmented by the negative pleural pressure. And so the pleura can drag the fluid into there without overt macroscopic obstruction, and simply because of the pressure gradient between the renal capsule and the pleura. And so the way we would go about to prove a urinothorax is by sampling the fluid in the chest. Vijay, have you ever seen urinothorax before? If not, how do you think you would go about trying to prove this hypothesis in real life?
I haven't seen a urinothorax. I would look for a pleural creatinine to the serum creatinine. So if the urine creatinine is, if the pleural creatinine is almost similar to the serum, then I think it makes the diagnosis of urinothorax confirmatory.
Yeah. And what do you expect Light's criteria to show for a urinothorax?
Yeah, I think this was the cause probably you are mentioning of transudative unilateral
Yeah.
effusion. So it is usually transudative.
Yeah, I think that transudative is usually because there is high pressure and the fluid leaks into the serosal surface. But because the vessel is intact from which it is leaking, all the proteins and the LDH do not leak out with it. So a transudate usually is as the development of fluid with an intact blood vessel. So if we think about where all effusions or fluid from serosal surface come from, they all come from blood vessels that leak. And so in transudate, what we're saying is the blood vessel is actually strong and fine, but there's high pressure inside it that allows fluid to leak, but the fluid does not contain heavy particles like LDH or protein. But you can have leaky vessels that leak fluid, but if that fluid does not contain protein or LDH, it can never show up as an exudate. So your urine, unless you have nephrotic syndrome, should not have high protein and should not have high LDH. So if you're having urinothorax, no matter what the underlying cause is, it'll show up as a transudate. So it's really, really important to recognize that there are two classes of transudative processes, either those that result from high venous pressure, whereby the intact vasculature that leaks the fluid blocks the release of proteins and LDH, or you are leaking a intrinsically LDH deficient and protein deficient fluid, like urine, CSF, peritoneal dialysis fluid, or chyle. And so here, I think it's really, really important to not sample this fluid, see that it's transudate, and diurese the patient. You need to step back and visualize the context. And the context here is what's happening in the abdomen. And so a urine, a pleural fluid to creatinine serum creatinine ratio would be very, very helpful here. And if we prove that this is a urinothorax, then the question becomes all about why the patient has an obstruction, because everything else is a consequence of that obstruction. Yeah, I'm right there with you, Vijay. I think sampling this fluid will be very, very illuminating. All right, Samir, tell us more, please.
Sure. So get my slide back. So I'll give the readout for the CT chest. It said large left pleural effusion with complete collapse of the left lower lobe. We did do a thoracocentesis. So it showed 1,300 white blood cells, neutrophilic predominance, 7,700 red blood cells, LDH 63 compared to serum 160, protein 0.4 compared to serum protein 7.8, and the cultures were without growth. The next aliquot will reveal the diagnosis.
Go ahead, Vijay.
I think so. It looks more a transudative fluid. According to the light by the light's criteria, it is transudative, being LDH and protein being normal. So I think this more strengthens our possibility of this being a urinothorax. Uh, uh, Dr. Samir, was any vessel imaging that was done in the thorax in the CT that was done? Just be because either the embolism can cause both exudate as well as transudate effusion. So I just don't want to miss out on that and anchor
There,
it on urinothorax.
yeah, so there was no comment on any of the vessels.
Okay. Thank you. So I think it strengthens the possibility of a urinothorax. So I think the problem that we are solving now is why is this patient having an abdominal or the flank pain that is still persistent? So I'm thinking, is there an underlying malignancy that is there, but we don't see any of the inflammation for malignancy. So I expect some inflammation, but however, it is not there. So other thing is there retroperitoneal component that is there? However, the CT abdomen didn't show or comment anything of the retroperitoneal process that could be present. There is no infection, so probability is a malignancy or uh, probably inadequate stenting. Maybe stenting maybe was required. So that is one thing that is I'm considering. Or I'm thinking how I would make progress is if I can sample the bladder thickening, if it could be sampled. So this is one more thing that I'm thinking of. Reactive inflammation. So there is no stones. So maybe stricture is another thing that I'm thinking of upstream. So that is also another process because nothing, whether it is within the ureter or the outside the ureter is what I'm thinking of. Intraluminal is extraluminal. So there is no signal for anything extraluminal that is seen here. So mostly intraluminal processes. So either is a stricture or the thickening, maybe a biopsy from there. So this is what I'm thinking.
Yeah, I think that's absolutely superb. I have nothing to add to your thinking. I think urology expert will probably needed to distinguish between an efficient procedure or a large staghorn calculus or whether there's something else going on. But I think you're seeing that everything else is a consequence of that. And ultimately, we should try to prove that with a pleural fluid creatinine to serum creatinine ratio. And if we do that, then we prove that the pleural fluid and the hydronephrosis are consequences of that core urological problem. So it's not many times in life where you ask a urologist to solve your pleural effusion, but today maybe today may be the case. Before we hear about the final answer, I just want to thank you, Samir, for presenting this case in such a manner that made the learning so rich. This is such a cool journey that we were on, but I think you allowed us to focus on the bread and butter first before we got very fancy schmancy and talked about this instance. So I'll pass the mic to you to tell us what happened next.
Yes, so the pleural fluid creatinine was 7.4 compared to a serum creatinine of 1.3. So everyone was right on the mark.
Yeah, Vijay, what are your thoughts? What did you learn?
Amazing. This is the first time I'm ever seeing a case like this. It is mostly what we read. Thank you for bringing this amazing case, Samir. So I think from uh, from the beginning, it looked like inflammation, and then the story completely changed. So my biggest learning here were a few things. So I think I early anchored on the possibility of post procedure and a PE that was a so I think slowing down a little more was I think that is one of my biggest things that I take. Uh, Apart from that, I think this should be a learning for me to see how I would make progress for the learning gaps that I have of the HUN. So how do I make progress with this? Um, yeah, this is
I thought that
how
was
I'm.
Vijay. I think you're showing us growth mentality by pushing yourself to the next steps. But I think you were right on the money from the very beginning. I think as a critical care physician, your bias towards more morbid diagnoses is very important. And if you're not going to think of them, then nobody will. And so I think that anchoring is only a problem when you drop your anchor and you leave it. I think being thoughtful about how the patient could suffer consequences is related but different. And so I don't think you had an anchor. I think you were using dynamic thinking along the way. And I think when the the story is a slowly progressive disease that doesn't take off, you then have to think, well, what is happening to this person that's making them slowly worse? And I think the pneumothorax hypothesis became less likely, a massive pulmonary embolism became less likely. And when the serum laboratory data showed an underwhelming inflammatory syndrome, like, oh, this is not even inflammatory. And then you're like, oh, wait, it might just be a simple plumbing problem. But I think along that way, you have to be more open to the scarier alternatives. And I think you were. But ultimately, I think sometimes it's the elegance of medicine that really humbles us all. I'm curious, Samir, what was it like for you to be involved in this patient? What did you learn from in real life and also presenting it here today?
Yeah, so I think being a part of this discussion, it really struck out to me how the patient's complaint, when presented, it's easy to reflex to a set of common diagnoses that we all know. But it was really instructive for me to see how he moved from that normal archetype of diagnoses to eventually honing in on a zebra. But it was only through kind of thinking those through really, really thoroughly. So I think that's really useful for me. I've never seen this kind of case before, and I didn't even know it was a possibility. So uh, I think this was really instructive for me. So I wanted to thank you guys for having me, and also to Dr. Rizai for helping me through this case.
Yeah, the pleasure is all ours. I would highly recommend to send your case presentation and put it on your CV, Samir, because I think it just illustrates how thoughtful you are, how much knowledge you must have to be able to put this case together and present it. So thank you so much for doing that. A huge plug for all of you to consider presenting your cases here because you will get mentorship and guidance from experts like Alec. Alex, any other thoughts you wanted to add or experiences from either reviewing the case or really any of your wisdom would be greatly appreciated.
Yeah, thank you so much, Samir. Awesome job presenting today. Actually, Samir didn't even see this patient. This is a patient that I
Wow,
saw before
that's
we even worked.
awesome.
Um, and yeah, the case was very instructive. And actually, I want to shout out Steph and Anne-Marie because they had just done their discussion on a case where a patient had like I'm blanking on the term, but basically had a urinary leak and had urine ascites. Thank you, Yusuf.
Mhm.
And so I had listened to that case about a month before, and then this case came in, and with the time course, and I was wondering about this, and
Wow.
we sent the creatinine, and I think at that time, urology felt that there was maybe sort of a micro leak related to their procedure that hadn't resolved yet. And so actually at that time, although he didn't leave the hospital with a stent after his procedure initially, after he had the urinothorax, they did place one. Fortunately, he did very, very well after they drained the effusion. He had a chest tube for a couple of days, and then, about a month later, after they took out the chest tube, he was doing very, very well with, resolution of his symptoms. So, yeah, I think it's an exceedingly uncommon diagnosis. People get treated for stones all the time and don't usually get a urinothorax. But I really love your discussion. And then, something that sounded so inflammatory initially turned out to be a transitate. And I love that you had sort of brought that up initially. But certainly a humbling, and I thought it was a very interesting case. And I'm really happy that Samir was able to share it today.
Thank you for bringing it in. And oh my gosh, I can't believe it was primed by the urinary ascites discussion that two VMR legends had. That's so, so cool. All right, last but not least, we'll hand the mic to Elena to recap the teaching points.
Yeah, thank you so much, Samir, for bringing such a fantastic case to us. And I think, although this is a rare diagnosis, I think Vijay's and Rabih's discussion has shown how far we can go with clinical reasoning. So the first point that I want to make that is actually going to take us through the whole case, and that is when someone has just had a procedure and they present with a chief complaint, it can either be a complication of the procedure itself, or it can be two totally different processes. With the complaint of dyspnea and chest pain, we were very focused on a cardiopulmonary disease process, but also a mediastinal disease. So as lungs usually don't cause pain themselves, we were considering from the very beginning that there must be a process outside of the lung, like the pleura, like the heart, or the chest wall. Vijay made a great point that with the left-sided nature, we have to think of a pleural disease, but also because of the post-procedural state, we have to think of an abdominal process. With the back pain, we also have to think of a catastrophe like dissection. And focusing on pleural processes, there's actually three kinds. You can have air, like in the context of pneumothorax. You can have ischemia in the context of PE, or you can have inflammation. And the Light's criteria and a thoracentesis can bring us very far. With the unilateral nature of the chest pain and the shortness of breath, the pleural process was very likely. The fact that the patient had a past medical history of type 2 diabetes, macrovascular disease is definitely something that we have to consider. The vitals and the physical examination that Samir presented showed tachypnea without signs of hypoxemia, decreased breath sounds in the left lung, and left-sided flank tenderness. So again, we go back to what kind of pleural process this could be. Could it be air? Could it be fluid in the lung? And POCUS will bring us very far, as we can look for signs of PE, we can look for gas, or we can look for a pleural effusion. We discussed a little bit about when we need a CT with contrast of the chest or without. And most of the time, because the air is a very good contrast medium, a CT chest without contrast will bring us very far. However, there are three instances where we need contrast. That is when we have to look for vessels, when we have to look for inflammatory pleural diseases, or if we want to visualize mediastinal structures better. As mentioned before, pleural fluid analysis can be seen in the context of Light's criteria. So we look for protein and LDH in the pleura. And if the vessel is intact, you shouldn't see any of that. So for exudative processes in the context of inflammation or malignancy or PE, we would see protein and LDH. However, in transudative processes, like in heart failure, the vessels are usually intact and we don't see any protein or LDH in the pleural fluid. So again, the one-sided process is suggestive that this is not a transudative process, but however, an exudative process is more likely. In the labs, we found that there is no overt inflammation. There was a mild elevation in the creatinine, some RBCs and white blood cells, and in the CT, we saw hydroureter nephrosis. And again, we go back to the first point that we made. Is this secondary to the procedure, or is this a different process, like a UTI? Okay, and then with the unilateral hydronephrosis, we were thinking mainly of the ureter and obstruction there, like in the context of stones, strictures, or a mass, although a mass is a little bit less likely. So then tying it all together, thinking of a pleural effusion in the context of an obstruction of the ureter, it could be due to a leakage in a pressure gradient in the context of ureteral obstruction, and that is called urinothorax. I've heard that actually for the first time today. And we could confirm this diagnosis by the transudative nature of the pleural effusion and the elevated pleural fluid creatinine. Yes, that's it from my side.
Absolutely amazing, Elena. Thank you so much for recapping the whole journey from beginning to end, including the theme at the beginning. I absolutely love that. Really, really marvelous job. Thank you again, Samir and Alec, for a really, really cool case, and Vijay for co-discussing. And last but not least, for Zachary, for getting your first scribing under the way. I thought you did an awesome job, and I see that you're doing it again tomorrow. So you'll get very good very quickly. All right, y'all. Hope to see you tomorrow. Have a great rest of your day. Thank you.